Hello, let's learn about multi-drug resistant organisms or MDR. As you can see from the chart, once upon a time a scientist named Fleming discovered the miracle of antibiotics. A scientist named Fleming discovered the miracle of antibiotics called penicillin. And from the year 1941, within a year, the antibiotic developed resistance. Similarly, for the other antibiotics, say vancomycin, methicillin, daptogor, within years of its discovery, the resistance were developed within 1 to 2 years. As Rasarealization Freeman rightly said, the microbes are educated to resist penicillin and a host of penicillin fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to the infection with a penicillin resistant organism. I hope this evil can be averted. It's rightly said, multi-drug resistant organisms are bacteria that are developed resistant to at least one agent in three or more antimicrobial categories. These antibodies are no longer be effective to control or kill the bacteria. MDROs are predominantly bacteria but can also include fungi, vira, or parasites. The name of some MDROs identify resistance to only one drug agent, but they are frequently resistant to multiple drugs. Each year, nearly 2 million patients in the US get an infection in the hospital. Of these patients, about 90,000 die as a result of their infection. More than 70% of the bacteria that cause hospital-acquired infections are resistant to at least one of the drugs most commonly used to treat them. Persons infected with drug-resistant organisms are more likely to have longer hospital stays and require treatment with second or third choice drugs that may be less effective, more toxic, and are more expensive. In most cases, the MDRO's infection has clinical manifestations that are similar to infection caused by susceptible pathogens. However, options for treating patients with these infections are often extremely limited. Although antimicrobials are now available for MRS and VRE, resistance to each new agent has already emerged in the clinical isolates. Similarly, therapeutic options are limited for ESBL producing isolates. These limitations may influence the antibiotic usage patterns in ways that suppress the normal flora and create a favorable environment for development of colonization when exposed to potential MDRO pathogens. That is called a selective advantage. Increased length of stay, mortality, morbidity has been associated with MDROs. The type and level of care influence the prevalence of MDROs. ICUs, especially those at tertiary care facilities, may have high prevalence of MDRO infections than do non-ICU. How do antimicrobial emerge? They emerge because of some mutations in the susceptible bacteria, by development of some resistance genes, or by permeability, alteration in the permeability of the cell wall. Most common challenging MDROs in healthcare are MRSA, that is methicillin-resistant Staph aureus, vancomycin-resistant Enterococcus, extended spectrum beta-lactamase, and carbapenem-resistant Enterobacter. Let's see about MRSA. MRSA was first isolated in 1960, but by the 1990s, it accounted for about 25% of the Staph aureus isolated from hospital patients. In 1999, MRSA accounted for more than 50% of the Staph aureus isolates. So the incidence of MRSA is increasing exponentially. As you can see from the chart, from 95 to 2004, it has increased from 30 to nearly reached to 70%. The methicillin-resistant Staph aureus. So the MRSA stands for methicillin-resistant Staph aureus. By definition, an MRSA is resistant to all the beta-lactam group of antibiotics, that is penicillin, cephalosporins, carbapenems, and monobactams such as H2NAM. Except the newer cephalosporins such as fifth generation cephalosporins like ceftobiprole and others. How does MRSA develop? It is because of alteration of the target site, that is penicillin binding protein PBP, which gets converted into PBP2A by production of a resistant gene called MECA. The Staph aureus cultured from any specimen that tests oxygen resistant or cephalosporin resistant or methicillin resistant by standard susceptibility methods or positive FDA approved direct testings like PCR. Resistance to penicillin, cephalosporins, and monobactams and carbapenems occurs in MRSA. And additionally, it can occur in amyloglycoside, macrolides, tetracycline, chloramphenicol, and lincoln. MRSA builds its cell wall using different building material compared to medicine-sensitive Staph aureus. So as said before, there is an alteration of the cell walls as compared to a medicine-sensitive Staph aureus. How to recognize an MRSA express test? Beta-lactam for Staph aureus is essential testing. Penicillin and either cefoxitin or oxacillin. Cefoxitin is recommended for testing and it is a surrogate for oxacillin. Oxacillin test is not reliable. Penicillin binding 2A is agglutination test. It does not detect all MRSA. So antigen antibody is based on antigen antibody principle. Not all the penicillin resistant Staph aureus are MRSA. There is alteration with targets at an MRSA. There may be penicillin resistance because of BLA Z resistance. MEC or MEC-C is responsible for the MRSA and detected by PCR or whole genomic sequencing. SCC, that is typical chromosomal cascade, MEC, typical cascade chromosomal MEC, SCC-MCC is the codon that is altered and responsible for the MRSA production. Common terminology when talking about MRSA is valid for all staph aureus and not only for MRSA. It refers to the SPA type, and PCR and sequencing of the gene is done to determine the type and order of lipids. MRSA groups include hospital acquired, community acquired, and livestock associated. But transfer of states between these settings is increasingly being recognized and is very differently in nature. Testing penicillin and cefoxitin and oxygen will allow the detection of MRSA resistance, MRSA isolations. MRSA are resistant to penicillins and cefoxitin and oxygen, but oxygen disc testing is not reliable. Hence, cefoxitin disc testing is used for detection of MRSA. Staph aureus resistant to penicillin only are not MRSA. Penicillin variant 2A augmentation test detects MRSA. Although rarely it is possible to find MRSA negative for MAC or MAC-C also. Now, recognizing the signs and treatment in early stages reduces the chances of the infection of MRSA becoming more severe. More severe and potentially life-threatening MRSA occur in hospital settings because of infection like bloodstream infections, surgical site infections, and pneumonia. According to the CDC, there are more serious infections by MRSA, and they have been declining as noticed in for several years. Most environmental infections are skin and subcutaneous infections that appears like furuncle, carbuncle, or pustules or boils, which are often reddish. They appear like spider bites, as seen from this. It's a classical picture of MRSA infection, like look like a spider bite. They can look like spider bite. They commonly occur at sites of skin trauma, such as scars and abrasions, and areas covered by hair, such as back of the neck, groins, or beards. MRSA infection can lead to abscesses and cellulitis. The risk factor that contributes to MRSA colonization or infection includes poor functional status, condition that causes skin breakdown, presence of invasive devices, prior antimicrobial therapy, history of colonization. Other risk factors include male gender, urinary incontinence, fecal incontinence, presence of wounds, pressure ulcers, antibiotic therapy, hospitalization in the last 6 months. What patients are more likely to shed the MRSAs? They include patients with heavily draining wound, then incontinence, diarrhea, colostomy, or patient who cannot or will not contain secretions and excretions, or very poor hygiene, difficult behavior that increase the risk of transmission and others. What are the treatment regimens for MRSA? Vancomycin is the drug of choice. However, the disadvantage of vancomycin is it's expensive, parenteral administration is an issue, then ototoxicity and nephrotoxicity, which can get potentiated along with so linezolid has been an alternative to vancomycin and can be administered. So, what is the colonization or carrier set of MRSA by healthcare professionals? Do not routinely culture the staff for colonization with MRSA. It may be needed as a part of an outbreak investigation. However, the healthcare professionals epidemiology has been linked to transmission. Before culturing, get expert consultation and action planning. Contact precaution with observation for complaints is required. Hand hygiene is required. If a decision has been made to culture the healthcare professional for nasal colonization, mucilation has been shown to be somewhat effective. Then Enterococcus faecalis, Enterococcus piscium, or Enterococcus species unspecified that are resistant to vancomycin by standard sensitive testing methods or by FDA approved method like PCR has been proved effective in detecting VRE. Resistant to penicillin, cephalosporins, monobacterium, carbapenems, and vancomycin is common, and the treatment of VRE is linezolid. A similar rise in prevalence has occurred with VRE also. From 90s to 97, the prevalence of VRE is increased from 1 to 15%. It occurs for about 25% of the enterococcal isolates. As like MR said, the VRE prevalence incidence is also increasing exponentially. Contact precautions is required. Culture negative prior to discontinuing precautions is required. CDC now says that we need to decide when to discontinue the precautions, but it may be prudent to have negative cultures prior to the discontinuation. Why contact precautions are required? It is required along with environmental contact. As we can see from this picture, there are many surfaces of the ICU areas which are often colonized with VRE. As we can see from the tables, beds, chairs, and ventilators and other areas that are often contaminated or colonized with. Then after from immersion where we have carbon enterobacteriaceae and E. coli, Klebsiella, enterobacter species that resistant to imipenem, meropenem, doripenem, and ertapenem by standard AST method or by production of carbapenems such as KPC, NDM, VIM, IM2 oxalate by post PCR can help in the detection of the carbapenem-resistant enterobacteriaceae. They are resistant to imipenem, meropenem, doripenem, or ertapenem. The treatment of choice for CRE is ceftazidime, iobactam, or gentamicin, amikacin, colistin, tigecycline, and fosfomycin. How does knowing resistance mechanism drive the appropriate therapy? This is well explained by the chart. If it is a KPC, wherein there is a hydrolyzing activity of penicillins, cephalosporins, and aztreonam and carbapenem, and the active antibiotics are colistin, polymyxin B, tigecycline, amroglycosid, fosfomycin, and others. While for MBLs, where the hydrolyze the cephalosporins, carbapenem, aztreonam, the drug of choice will be colistin, polymyxin B, fosfomycin, carbapenem, aztreonam. Similarly, for OXO 14 and OXO 23, colistin, tigecycline, fosfomycin, cephalosporins, ceftazidime, iobactam. Let us see about the extended spectrum of beta-lactamases. Bacterial enzymes capable of hydrolyzing and thus conferring resistance to all the first, second, third generation cephalosporins, penicillin, and aztreonam are seen in ESBL producers. Resistance to cephalosporin and cephalosporin is the screening criteria for ESBL. The treatment of choice is carbapenems or beta-lactamase inhibitors like Peptaz or Jivsect. Now, let's say about beta lactamase. What are they? They are the enzymes produced by bacteria that provide resistance to certain antibiotics. They can affect both. They can be produced by both by gram positive and gram negative and on both chromosomes. And examples of beta lactam antibiotics like penicillin, cephalosporin, carbapenems. And the mechanism of action of beta lactamase is that they cause hydrolysis of the beta lactam ring. The opening of the ring causes the drug to become. The story is more complicated. Multiple antimicrobial resistance is often a characteristic of ESBL producing gram negative bacteria. Genes coding for ESBLs are frequently located in plasmid and they carry the resistance genes to other antibiotics like aminoglycosides and cotrimazole and others. The resistance to beta lactamase comes in many forms. It causes decreased cell permeability, alteration of the target site, enzymatic inactivation, or act to export out. That is, act to increase efflux of the antibiotic from the bacteria. So that was about the multidrug resistant organisms. Thank you.